Thank you, Chuck, and thank all of you for being here this morning. We're having the scholars join us here. We're going to have a short panel where we ask each of them to talk a little bit about their projects and themselves. I'm Cheryl Moyer. I am faculty in the Department of Learning Health Sciences with a joint in OB-GYN and in public health. I'm also the associate chair for DEI in our department, which means that I am working with Greg Merritt, as Chuck just introduced, on our PHEC, which I'll talk about after this. We're talking with the panelists of our trainees now, and then we're going to talk a little bit more detail about the PHEC and the REC and the RDAC. The goal of this panel is to allow the scholars to learn from one another about how they're thinking around patient engagement, and also to show each of you what they're thinking about and the diversity of the types of projects that they have. So I am just going to allow each scholar to introduce themselves and tell us briefly a little bit about you, why you wanted to do MEL STaR, what your project is about, and how you're thinking about patients and how you would engage patients. Go ahead.
Hi, everyone. My name is Zhen Zhang. I am a medical physicist and clinical track faculty within the Department of Radiation Oncology. And to anyone who doesn't know what medical physics is, it's a very common question. I have settled on this analogy. We are basically pharmacists in radiation oncology departments. We ensure that doses go to the right place and in the right amount, in the correct dosing schedule. And our profession, I think the pioneers of our field has done a really good job promoting this type of job into a profession and supported by professional societies. And we're very focused on quality assurance, and we're ensuring the machines actually exactly work the way they should be. The plans we create actually does deliver doses it's intended. But I think that great legacy sometimes also kind of feels like a baggage, which is an increasing amount of us feel like we meet too much quality assurance, have done too little quality improvement. And so since I joined the department, I have been trying to find out if there's an opportunity for me, because I can definitely feel like I need more training. And I was trying to find out, and there's expertise on the academic departments, but building the bridge is hard. And so after a couple of years, I joined the university in 2022. I found there is actually a Department of Learning Health Science is actually doing that, building bridges and connecting with talents and providing a continuous quality improvement kind of angle and a patient-centered perspective to this. Because I think ultimately the reason why I wanted to do this project is that ultimately patients don't really care about if it's precise radiation or whatever. Patients just want better care. So my project is an infrastructure project that's, so there's a lot of work done already by the informatics team led by Dr. Chuck Mayo in our department many years before I joined the department. And my current focus is trying to extract as much useful information from the notes, unstructured notes, to build that infrastructure. And the way I was hoping to engage patients and then patient partners is, help me prioritize the data elements that should go into the database. And secondly, I think we're very aware of the pitfalls of building a large database, which is you can try to build a shoe that fits everyone, but ends up fitting no one. So what we want to make sure is that the shoe, the infrastructure we build, actually can fit our ultimate goal, which is patient-centered outcome and comparative effectiveness studies. And I also want to add, since I have met my patient partner mentor, I found that there's another aspect I could use some help, which is positivity and optimism. I think academia is filled with negative feedback. There's reviewers. There's all kinds of reviewers. But I think any patient partner who have gone through the process, they have the lived experience. Even if they're a caregiver, they have some sort of inner strength. And I have felt that since my first meeting, so I'm very much looking forward to the whole experience. And I'm very grateful that I'm selected to in this program.
I love that. Trevor?
Hi, I'm Trevor Denton. I'm a doctor of physical therapy and a project manager in the Division of Hospital Medicine, which is part of the Department of Internal Medicine. A reason why I was interested in MEL-STaR is because a lot of work that we do is on research studies, quality improvement, and implementation science. And I was really encouraged to do this program from my great boss, Dr. Stephanie Taylor. So that's really what has encouraged me to join the program. Overview of the project, it's called ROAM, Recovery of Older Adults Through Movement. And so about 1 in 3 elderly patients experience hospital-associated deconditioning. And so this is something that happens during their hospital stay. And we really want to decrease that. And so we're trying to come up with some solutions. One of them is an intervention where we use technology. Over 80% of people over 65 have smartphones is what we found out. And so we want to create an app that just prompts patients to make sure they keep moving. Kind of like a quote that I've kept in my head is that instead of having a patient's room more of like a jail in a way where they're kind of in lockdown, we want it more like a hoteling space where they're able to move freely, get up, go to the bathroom, make sure they're up during meals. And so that's what we really want to do with the app. And so with the patient engagement piece, that's always huge. As a physical therapist, I'm always working very closely with patients and making sure that you're fitting what you're doing to them instead of just kind of like going through a protocol or whatever. And so that's been really helpful. We want the app to be usable, accessible, and feasible, and so that's where the patients will come into play. Thank you.
Great, thank you. Molly?
Hi, I'm Molly Hunter. I'm a clinical assistant professor within the Division of Acute Care Surgery, and I'm also one of the burn surgeons here at Michigan. And my project is looking at how to utilize telemedicine to improve our burn transfer system. So one of the things about burn, and as you walk around, you'll see my poster, it still relies on expert evaluation for accurate diagnosis. And currently, we don't have a way to expand the expertise from our burn center. A lot of times you're on the phone, somebody who is not an expert describing something to you, and you have to decide whether or not to transfer that patient. And so my hope is that we can utilize photographs in a patient-centered way, meaning like protecting privacy, to be able to improve our triaging for burns throughout the state. And I think, so I was excited to partner with MEL-STaR in this because I think there's a lot of opportunity for improving care in the burn world with implementation science, because it's a very team-oriented, systems-based practice. And so I think that really makes a lot of sense. For my focus, so I'm actually partnering with one of our burn survivors through the STaR program, which is survivors offering assistance in recovery. So these are survivors that have been trained to help new survivors get through the process of recovering from burn injury. And so I think he'll have great insight into the patient perspective of photographs being transferred from one center to another. And then I think the big piece of this is equity, which is being able to expand the burn expertise of a verified burn center here at Ann Arbor, but even up to the Upper Peninsula and other rural areas where those providers, kind of struggle sometimes to know what to do. And sometimes people end up traveling long distances when they didn't have to. And then, of course, sometimes not traveling when they should. And so making sure that we improve our triage system to improve access to burn expertise.
Natalie?
Hi, I'm Natalie. I'm an MD PhD student in the program. As for why I was drawn to MEL-STaR, I think I was really attracted to the fact that there's so many different types of mentors. And as a student, I think at different times I'll be calling on a lot of different mentors. As for my project, I'm with the Michigan Surgical Quality Collaborative. And part of this collaborative is there's 70 different hospitals that participate. And each year there's different quality improvement initiatives that the hospitals can participate in and receive points for pay for performance. So there's an incentive to participate. And right now these initiatives are primarily decided by the leadership within the Surgical Quality Collaborative. And my goal is to kind of create more bottom-up quality improvement initiatives and do this through creating an innovation competition, so very similar to Shark Tank, and using implementation science to kind of properly plan for that. And the patient, I think, was really gonna come into play in terms of the overall goal of kind of my MEL-STaR project, which will be my dissertation as well, is looking at how you can create organizational alignment. So taking into account leadership priorities as well as participant priorities. And I think going a step even further than most organizations do and having patient priorities incorporated, since the whole goal is around improving patient care and ensuring that kind of leadership, hospital surgeons and patients are all represented in the priorities for the quality improvement initiatives each year.
Great. Anjali?
Yeah, hi. I'm Anjali Shah. I'm ophthalmologist, retina specialist at the Kellogg Eye Center, and or the Department of Ophthalmology. I also have an administrative role, and at the intersection of those two roles, I became very interested in no-show rates, which are a problem throughout healthcare. As we all know, no-show rates impact patient outcomes. If you don't show up, you don't get good health care and have good outcomes. They impact the provider, they impact the health system, and they are a significant equity issue. There are certainly equity reasons for why patients do not show up to their appointments. And so I am interested, and my project involves trying to better understand factors that contribute to no-show rates, and then trying to create interventions to improve appointment adherence. Specifically in ophthalmology, I don't know for sure, but I think that ophthalmology has very unique factors that contribute to poor appointment adherence, such as, poor vision and sort of even larger transportation issue than sort of the average patient would have. And I think my patient mentor is a patient of mine, and someone who actually fits the highest risk no-show category, but yet seems to be able to find her way to every appointment. And I think that she'll be critical in helping us identify places to look for interventions, ways to design interventions, and providing a perspective as to why it's so challenging to get in for these appointments.
Great. Dorsa?
Hi, my name is Dorsa Ghaffari. I'm a CTS fellow at MISHAR. So me and Eli, we're working on a project in the Department of Neurology. So when I was a grad student, my work was still in neural engineering. I was doing a lot of computational modeling and working with animals. And then at some point I started working with human subjects, and they would, the big part of why I got really interested in working with human subjects was that they would give us feedback, and it was like, oh, we could have done this from the beginning, and this is where the actual positive effect can happen. I'm more close to having an effect on patients' lives. So I started being more interested in clinical research, and the reason I'm interested in the MEL-STaR program is that it's really encouraging the patient to include patient partners right off the bat. So yeah, the project that I'm working on is to have a clinical study of an algorithm that predicts surgery outcomes for epilepsy patients. So currently, when epilepsy patients go through resection surgeries, they take basically parts of their brain out. Only 20 to 60% of those patients are seizure-free. So the results are very inconsistent, and it depends really on that clinician's decision based on looking at the EEGs and which parts of the brain they choose to resect. So this lab that I'm working with, they've come up with an algorithm that uses a new biomarker for good outcomes of the surgery. It basically it looks at a bunch of different stuff, but mostly high-frequency oscillations. So those electrodes that have higher high-frequency oscillation rates, and they give each electrode a rating for how important it is. So basically, we are trying to do a clinical study of that and see how presenting that new information to clinicians is going to affect their decision-making and eventually expanding it to other hospitals so that decision-making is more uniform and less clinician-dependent.
And Amir?
Yes, it's working. Hello, everyone. Good morning. My name is Amir Azizian. I am also a New Hills PhD student. I'm coming from Saskatchewan, Canada. I got my master's degree in community health and population sciences, community and population health sciences from University of Saskatchewan. And also I have a medical degree from Iran. So I practiced as a family physician in Iran for a few years, then moved to Canada. In terms of the project that I'm involved with, the title is My Path Hypertension Story Booth. So the PATH network is part of the PCORI partner network. And there are, I think, 9 organizations and institutions that are collaborating in the PATH network. The PI for the project that I am collaborating with is Dr. Kathleen McTighe. She's at the University of Pittsburgh. My project specifically is trying to look at how the stories collected via the hypertension story booth can enhance or improve the understanding and management of hypertension treatment and planning and care for patients. I am part of the hypertension learning community, and my patient mentor is one of the members of the learning community. I'm kind of new to this program and learning community, so I'm trying to hash out my role, but basically I will be collaborating with the patient partner and the members of the learning community to do literature search, set priorities for future research. My goal is to empower the patient partner that I'm collaborating with to set the outcomes of interest for the research that the hypertension learning community will pursue, and also help the clinicians and researchers to hear patients' voices more. And that's my story. Thank you.
Perfect. I'm going to ask the scholars to stay here, and we're going to transition into a little bit of a description about the PHEC. As you heard, they all have very different projects with very different potential roles for patients. I so wish Greg was here, because Greg has that fire in the belly for patient engagement that is really hard to replicate. So forgive me as I try to fill his shoes. But one of the things he often says is, imagine a world where we can't fathom doing research without patients, like as in patients as partners, not just patients as consultants to content and little focus groups. And I was thinking, years ago, we did research without ethical review. And we can't fathom doing that now. And maybe one day we'll get to a place where we don't think about doing research without having a patient at our elbow saying, have you thought about this? And have you thought about that? So the point of the PHEC is to keep that bug in their ear, and frankly, to keep that bug in your ear as well, as we go through these processes. The PHEC is charged with ensuring that we integrate both patient engagement principles and health equity principles in all aspects of MEL-STaR. So that means the training, that means the mentorship, that means the small group discussions, so that every time we get together, there's a discussion of, what about patient engagement? How is that working? How can we work to improve that? Have you thought about health equity? And health equity is an enormous umbrella. It's not just race and ethnicity. There's a whole bunch of aspects of health equity. So at the end of this year, we will be asking all of our fellows, how did patient engagement figure in your project? And if they say it didn't figure at all, then we have failed. We're going to be asking them, how did our discussions about health equity impact the way you did your work? And if they say, what discussions of health equity? Then we know we will have failed. So our role truly is to make sure that we stay front and center with this patient engagement and health equity piece. And as Chuck mentioned, that's unique. Those other 16 centers, they're kind of, yeah, we'll do some patient focus groups, and maybe we'll ask some patients for input on our surveys, but they're not trying to have a patient mentor. And when we say patient mentor, we mean equal, so that partially is on us and you all to make sure that when patients are here and they're at the table, they're made to feel like equals, because they do have valuable input. So we often slip into jargon that we need to step back from. We often take for granted that all these weird processes at the U, I mean, don't even get us started on trying to get Greg as a business person an ERA Commons name, because that's impossible, right? So there's all these sort of obtuse university policies that can make patients feel boxed out. So as you as lab mentors and as rec mentors and RDAC mentors and as our scholars, part of it is to be constantly thinking about how can we ensure that we get the most out of patients and that they feel like they're contributing as well. What's the benefit to them of coming to these meetings? So as we've heard, I mean, I love Zhang's comment about patients being positive. Imagine that, if we thought about things from a positive angle instead of the deficit angle. But anyway, to make a very long story short, Greg and I and Diana are the PHEC team with others. It's not just us, and we are a resource for you. We will be meeting with fellows throughout the year and meeting with you all as needed to make sure that we can create an opportunity for you all to really benefit from engagement with patients, for you to think differently about health equity, and to make sure that that is a key component of the research.